Imagine for a moment you're, say, an ambitious cricketer, maybe playing at a high amateur level, or perhaps a professional rugby player. You dislocate your shoulder. It's painful, obviously, frustrating. But you do the recovery, all the physio, you build the strength back up. You think, okay, I'm clear. But then, thwack, it happens again. And maybe again after that. That's the crushing reality of recurrent shoulder instability. It's this relentless problem. It doesn't just sideline careers, it can really impact your daily life, strips away confidence, limits even simple things, that frustration, of a part of your body just refusing to stay put. It can be immense, huge career implications, not just for athletes, but other professionals too. And the emotional toll, of course. Now, for far too long, considering how common this is, there's been a surprising lack of a clear, agreed-upon gold standard treatment, really quite surprising. And this has led to, vastly different surgical approaches across the world, often influenced more by where a surgeon trained or the local traditions rather than perhaps what the most robust, up-to-date evidence actually suggests. So today, we're embarking on a really insightful journey into this critical area of orthopedic surgery, an area where, maybe surprisingly, treatment decisions have often been shaped by, let's say, inherited wisdom and regional habits. Our mission, it's clear. We want you to gain a crystal clear understanding of what the very latest, most comprehensive analysis reveals about treating this recurrent shoulder instability effectively. We're aiming to cut through the noise, bring you the definitive insights, and to help us navigate this, intricate and often debated landscape, we are incredibly privileged to be joined today by Professor Mo Imam. His deep expertise and, importantly, his recent significant contributions to synthesizing the critical evidence in this field are genuinely setting new benchmarks for clinical practice. Professor, it is an absolute pleasure to have you with us for this deep dive.
It's genuinely a pleasure to be here, a really vital topic to explore for patients and clinicians too.
Professor, before we get into the specific treatments, could you maybe help us grasp the sheer scale of this, the profound impact of recurrent anterior shoulder instability? Who typically gets affected most? And crucially, what are the bigger long-term implications if it's not properly addressed? It sounds like it's much more than just a temporary setback.
You've hit on a crucial point there. Recurrent instability of the shoulder is, it's far more than a minor issue. It's a truly significant, often quite debilitating complication after that first dislocation, or even sometimes after a less severe subluxation. When you look at the statistics, they are quite sobering, actually. Data shows that up to 60%, 60, of patients who have an acute traumatic anterior shoulder dislocation will unfortunately go on to suffer from recurrent instability.
60%, wow.
Yes, it's a massive proportion. And what's particularly striking, and frankly quite concerning from a clinical view, is this inverse relationship with age. Put simply, the younger you are when you first dislocate your shoulder, the dramatically higher your risk of it happening again. To give you a concrete example, take a 20-year-old male patient. After their first traumatic anterior dislocation, the risk of it happening again can be astonishingly high, up to 72%.
72%.
Indeed. Think about that. Almost 3/4 of young men in that age group could face this problem repeatedly. This figure really highlights that this is overwhelmingly a problem affecting young, active people, often at the peak of their physical activity, whether that's sport or demanding jobs.
72% for a 20-year-old, that's, nearly 3 out of 4. That's not just a clinical statistic, is it? It sounds like a profound, almost life-altering risk for someone just starting their adult life or, say, building an athletic career. It really underscores why just treating the first injury isn't always enough. We need solutions that truly prevent it happening again.
Which is exactly what your analysis looks at. Are there specific risk factors then, things that make some people more susceptible than others?
Absolutely. Beyond age and the, traumatic nature of the initial event, we've identified several key anatomical and patient-specific risk factors. These significantly contribute to these high recurrence rates. They include specific bony lesions on the shoulder joint surfaces, for instance, a Hill-Sachs lesion. That's an indentation or compression fracture on the back of the humeral head, the ball part of the joint. It happens when it hits the front of the glenoid socket during the dislocation. Then there's the Bankart lesion. This is where the labrum, that crucial ring of cartilage that deepens the socket, gets torn away from the bone.
Both of those indicate structural damage that basically compromises the shoulder's stability. Other factors include the patient's sex. Males often have higher recurrence rates, their age, as we just discussed, and the presence of what we call hyperlaxity.
Hyperlaxity.
Yes, essentially meaning someone is naturally double-jointed or has very flexible joints. This predisposes them to instability. These elements act as, predictors for who might struggle with recurrent dislocations.
So it's not just about the initial pop out of joint, it's about underlying structural issues, maybe bone damage, maybe torn tissue, and even a person's natural joint flexibility. That paints a much clearer picture of the vulnerability. And you mentioned the impact on patients' lives earlier. Could you expand on what disabling affliction really means for these young, active people? What's the real-world consequence?
Yes, the term disabling affliction is chosen quite deliberately because that's precisely what it can be. For young, active patients, athletes especially, this isn't just an inconvenience. It can be genuinely career-ending. Think about a professional athlete, a rugby player needing to make powerful tackles, maybe a tennis player serving with force, or even just an avid recreational climber who absolutely relies on full shoulder stability. If their shoulder consistently gives way, they're suddenly unable to participate in their sport, their pre-injury activities. It fundamentally limits their participation, their performance, and often their professional livelihood. We often see patients who just can't return to their prior level of activity, or they live with this constant apprehension, this fear of it happening again. That affects their mental well-being just as much as their physical capacity. It's profoundly limiting. And for our discussion today, it's important just to clarify. When we use the term instability, we're encompassing both subluxation, where the joint partially comes out and then goes back in spontaneously,
Right.
and frank dislocation, where it completely separates and needs someone to put it back in. We treat them as a single clinical entity here because both represent a failure of the shoulder to stay stable and can have similar underlying issues and long-term consequences. Beyond that immediate impact on activity and function, there's a really critical long-term consequence, one that often gets overlooked perhaps, but is maybe one of the most compelling reasons for definitive treatment. Recurrent instability has been positively correlated with a significantly increased risk of subsequent degenerative joint arthritis decades later. Potentially, yes. What this means is, if these recurring dislocations or subluxations aren't definitively treated, the cumulative trauma to the joint, the repeated impact, the wear and tear can lead to premature degeneration of the joint surfaces. This can cause debilitating arthritis decades down the line, long after their athletic careers might have ended. So treating this effectively isn't just about getting someone back to sport quickly, it's profoundly about protecting their long-term joint health and their overall well-being. This really underscores why finding the optimal, evidence-based solution, one that offers true long-term stability, is so absolutely crucial, both for immediate relief and for sustained quality of life.
That truly highlights the gravity, doesn't it? It sounds like a problem that doesn't just impact immediate function, quality of life, but casts this long shadow over a patient's joint health for decades. It really brings home the urgent need for effective, evidence-based solutions, not just quick fixes. Given this pressing need, Professor, two surgical procedures seem to, well, dominate the conversation for definitive treatment, the Bankart procedure and the Latarjet procedure. Could you walk us through what each of these involves and shed some light on why there's such a noticeable divide globally in preference for one over the other?
Certainly. These two are indeed the primary surgical options for recurrent anterior shoulder instability, and they approach the problem from, well, fundamentally different anatomical and biomechanical angles. Understanding their differences is really key to appreciating the debate around them. Let's start with the Bankart procedure. At its core, this procedure is about repairing the damaged soft tissues, the bits that were torn during the dislocation. Specifically, it involves retensioning the anterior capsule that's the main ligament structure at the front of the shoulder, which can get stretched or torn, and crucially, the direct repair of the avulsed labrum. As we discussed, the labrum is that vital ring of cartilage around the shoulder socket, the glenoid. It deepens it, helps stabilize the joint. When the shoulder dislocates, this labrum can be torn away from the bone that's the specific Bankart lesion.
Right, the torn cartilage ring.
Exactly. The procedure typically uses strong sutures, or sometimes small, absorbable suture anchors put into the bone, to reattach this torn labrum and tighten up the stretched capsule. The aim is basically to restore the natural anatomy of the joint. Now, the Bankart procedure was initially described way back, actually, but gained wider recognition and refinement much later. It has since evolved, so it can be done through open surgery, a larger incision, or, much more commonly today, arthroscopically.
Keyhole surgery.
Precisely. Using small incisions, a tiny camera to see inside the joint, and specialized instruments. Its widespread adoption is quite remarkable. Historically, something like 90% of surgeons internationally, particularly in North America and parts of Europe, have favored arthroscopic Bankart repair as the first-line treatment, mainly due to its minimally invasive nature and the perception of restoring the anatomy.
So the Bankart is essentially patching up the soft tissue damage, like sewing up a tear, really. And it's been the go-to for a long time, especially the keyhole version. That makes sense. The appeal of less invasive surgery is obvious. But what about the Latarjet procedure then? How does that differ? And why is there such a strong alternative preference in some places?
That's a perfect segue, because in stark contrast, we have the Latarjet procedure. Sometimes it's more descriptively called the coracoid bone block procedure. This is a more involved surgical technique. It addresses not just the soft tissue damage, but also, and this is critical, potential bone loss or significant structural deficiencies around the glenoid socket itself. It involves transferring a specific piece of the coracoid process that's a small hooked bit of bone that normally sits off the shoulder blade along with its attached conjoint tendon, which includes parts of the biceps and coracobrachialis muscles.
Okay, so you're actually moving a piece of bone.
Exactly. This bone block, with the tendon still attached, is then precisely positioned and secured with screws onto the front rim of the glenoid socket. It essentially extends and reinforces the socket forwards. The mechanism here is ingenious, really. It's twofold. Firstly, it creates a physical, bony block, a buttress if you like. It physically stops the humeral head from slipping forward out of the joint. Secondly, those transferred muscles, which stay attached to the moved bone, provide a dynamic stabilizing effect. So when the arm moves into positions where it might normally dislocate, these muscles contract, pulling the humeral head back into the socket, an extra layer of stability. This procedure was initially described by Dr. Michel Latarjet back in 1954, and he later modified it in 1980. Now, what's truly fascinating about the Latarjet is its very distinct geographical preference. While Bankart dominates in many regions, you see this stark contrast in places like France. For example, our research indicates that an astonishing 72% of French shoulder surgeons prefer the Latarjet procedure as their first-line treatment.
72% compared to 90% internationally favoring Bankart.
Precisely. It truly illustrates the powerful influence of tradition, surgical training environments, local schools of thought on established surgical practice, often more so than global consensus based purely on evidence.
That is a staggering regional difference. It's almost like different medical dialects have evolved over time. And this brings us perfectly to what you've termed the consensus gap. Could you elaborate on this core problem? How has it impacted treatment decisions, especially given the historical limitations in the available research you mentioned?
Exactly. This geographical divergence really brings us to the heart of this consensus gap, a situation where there's no universally agreed upon gold standard treatment. The core problem has been that the choice of which surgery to perform has largely been based on a surgeon's training background, their personal experience, maybe the prevailing traditions within their region or hospital, rather than on robust, high-level comparative evidence. This has led to significant variation in care. And frankly, it's left many patients, and indeed clinicians, without a definitive answer on what the optimal approach truly is. For a long time, the academic challenge was made worse by inherent limitations in the published literature. Many prior studies were restricted to older retrospective reviews looking back at patient data, or perhaps single surgeon series, where one surgeon reports on their own patients. Now, while these studies can give valuable initial insights, they inherently carry significant risks of confounders, other factors that might skew the outcomes and bias.
Right, like maybe surgeons choosing Latarjet only for the really bad cases.
Okay. Exactly that sort of thing. A surgeon might unconsciously select Bankart for less severe cases and Latarjet for more complex ones, which makes a direct comparison unreliable. Such studies, while useful, couldn't definitively or systematically compare the efficacy of these two very different procedures in a truly unbiased way. This situation starkly underscored the critical need for a more comprehensive and systematic analysis, one that looks at all the existing evidence, carefully pooling the data to really understand which procedure offered the best, most durable outcomes for patients across the board. That's the gap our work aimed to fill.
That deeply entrenched preference, almost like an inherited surgical philosophy, is really eye-opening, especially when science could potentially offer a clearer path. It makes the kind of rigorous analysis you've conducted even more vital for orthopedic professionals, for anyone trying to make the absolute best decisions for patients. So let's talk about that path. How exactly did you and your team go about rigorously comparing these two procedures? How did you try to cut through that traditional bias and give us more definitive answers? What was the methodology behind this deep dive?
That's a critical question, because the strength and reliability of our conclusions fundamentally hinge on the meticulousness, the rigor of our methodology. Our study was designed as a systematic review and meta-analysis. For those unfamiliar, this is generally considered the highest level of evidence when you're synthesizing existing research. It involves a structured, comprehensive search for all relevant studies on a topic, followed by a statistical pooling of their results. It represents, to date, the largest and most up-to-date comparison of these two specific procedures, Bankart versus Latarjet, in the published literature. To give you a sense of the sheer volume, the statistical power of the data we examined, our analysis pooled information from 7 distinct cohort studies. These are studies that follow groups of patients over time. Collectively, these studies involved a substantial total of 275 patients.
Over 3,000 patients. That's significant.
It is. To break that down further, 2,791 individuals had undergone the Bankart repair, while 484 had the Latarjet procedure. This extensive patient population allowed us to conduct a truly robust, powerful examination of the comparative outcomes. It gives our findings significant statistical weight. Our search strategy was incredibly comprehensive, designed to capture virtually all relevant studies published up to January 2018. We systematically searched across all the major medical and scientific databases: PubMed, Cochrane Central Register Controlled Trials, Scopus, Ovid, Web of Science. This broad systematic approach was absolutely essential to ensure we didn't miss any pertinent research and thus reduce the risk of what's called publication bias, where studies with certain results might be more likely to get published than others.
So you cast a really wide net, gathered all the relevant data. Once you had all these studies, how did you then go about aggregating and analyzing such different types of data? You mentioned things like operative time versus whether someone got an infection. How do you compare those statistically?
That's a great question. It's all about matching the right statistical tool to the nature of the data we were analyzing. For what we call continuous data, things like operative time, measured in minutes, or patient-reported outcome scores, like the Rowe score, which are numerical scales, we pooled these as mean differences. This simply allowed us to calculate the average difference in these measures between the two groups, the Bankart group and the Latarjet group. So, for example, we could see if one procedure, on average, took significantly longer or resulted in a higher average score. But for dichotomous data, that is, outcomes that either happened or didn't, a yes or no event, things like whether the shoulder experienced another recurrence, if a revision surgery was needed, if there was a full redislocation, the development of arthropathy, or complications like infection or hematoma.
The binary outcome.
Exactly. For those, we pooled the results as risk ratios, often abbreviated RR, with 95% confidence intervals. A risk ratio is a very powerful measure. It tells us how many times more likely an event was in one group compared to the other. For instance, if the risk ratio for recurrence was, say, 2.5, it would mean that recurrence was 2.5 times more probable in one surgical group compared to the other. The 95% confidence interval just gives us a range of certainty around that estimate. Now, to ensure the utmost methodological rigor and to minimize any potential bias throughout this complex process, we adhered strictly to the PRISMA guidelines. These are the internationally recognized standards, a checklist, really, for systematic reviews and meta-analyses. They ensure transparency and reproducibility. Our eligibility screening process, deciding which studies to actually include, involved 2 meticulous steps. Each step was conducted independently by 3 experienced reviewers.
3 reviewers, independently.
Yes, that redundancy helps ensure that studies are included or excluded consistently and objectively. It prevents any single reviewer's potential bias from influencing the selection. Similarly, the crucial task of data extraction, pulling out all the relevant numbers and facts from the selected studies, was performed independently by 3 different authors. Any disagreements at either stage, screening, or extraction were thoroughly discussed and resolved by consensus among the reviewers. This multi-reviewer approach is vital for building confidence in the dataset. Furthermore, we rigorously assess the quality of each included study using the Newcastle-Ottawa scale. This is a widely respected tool that evaluates studies based on 3 key things: how carefully the study participants were selected, how comparable the groups were for important factors that could influence outcomes, and how robustly the outcomes themselves were measured. The included cohort studies in our meta-analysis achieved a high mean score of 8 out of 9 possible points on this scale.
That sounds very good.
It is, yes. It's an excellent indicator. It means they were generally of good methodological quality, which further strengthens the credibility and reliability of our pooled results. Finally, and this is where our analysis perhaps made a particularly vital contribution, we placed a crucial focus on follow-up time. This was critical because previous analyses hadn't systematically looked at how the differences in outcomes between the two procedures might evolve, might change over time. There was a growing body of newer evidence suggesting that the true long-term advantage of one procedure over the other might only become really clear with longer observation periods, not just looking at immediate post-op results.
Right. Things might look similar early on, but diverge later.
Precisely. Our included studies had follow-up periods ranging from as short as just 30 days right up to as long as 10 years. This broad range allowed for a truly comprehensive long-term analysis, especially using what we call subgroup analysis based on different follow-up durations. This temporal dimension allowed us to see if, for example, a procedure that seemed comparable in the short term might actually be significantly less effective or even fail more often in the long run. It paints a much more complete picture of durability.
That's a truly impressive level of methodical investigation, Professor. It really underscores why your findings carry so much weight, moving beyond maybe anecdotal experience or single studies to what the collective evidence truly shows. Now, let's get to those critically important results. For patients, and indeed for clinicians, the ultimate measure of success in shoulder stabilization surgery often boils down to one thing: preventing the shoulder from dislocating again. What did your rigorous analysis reveal regarding recurrence and redislocation rates for Bankart versus Latarjet? Were there any surprises?
This is indeed the most critical finding for everyone involved, and our analysis revealed a very clear, and I would say quite stark difference. When we looked at overall recurrence rates, and by recurrence, remember, we mean any instance of the shoulder feeling unstable, whether it was a minor subluxation or a full dislocation after the surgery, the findings were absolutely compelling. The arthroscopic Bankart procedure was consistently associated with a significantly higher risk of recurrence compared to the Latarjet procedure. Specifically, the risk ratio, the RR, was 2.87, and the p-value was very low, less than 0.0001, indicating high statistical significance.
2.87. So what does that mean in practical terms?
In practical terms, it means the patients undergoing a Bankart repair were nearly 3 times more likely to experience some form of recurrent instability compared to those who had the Latarjet procedure.
Wow. Nearly 3 times more likely.
Exactly. That is a substantial and, crucially, a statistically highly significant difference. It's not a marginal variation. It's a profound distinction in the stability offered.
Okay, that's dramatic for overall recurrence. And how did that play out for actual full-blown dislocations? Was the pattern similar there?
Precisely. The pattern was strikingly similar, reinforcing that initial finding. When we focus specifically on overall redislocation rates, which refers to the shoulder fully coming out of the socket again, the picture was equally clear. Arthroscopic Bankart was also strongly linked to a higher risk of actual redislocation, with a risk ratio of 2.74 and a p-value of 0.03.
Yeah.
Again, this indicates a substantial and clinically meaningful difference in the long-term stability offered by the two procedures. Now, here's where our study makes perhaps its most significant contribution. Understanding the long-term perspective. We specifically focused on how these outcomes changed over time, because as you said, short-term success isn't always the whole story. What we discovered was that the pronounced advantage for the Latarjet procedure in preventing recurrence became most evident with longer follow-up periods. This difference became particularly clear and statistically robust between 6 and 10 years postoperatively.
6 to 10 years later.
Yes. In that extended window, the risk ratio for recurrence with Bankart actually escalated to 3.00.
Just 3 times the risk again in the long run.
It's exactly. After 6 to 10 years, patients who underwent a Bankart repair were truly 3 times more likely to experience their shoulder coming out again compared to those who had a Latarjet. This isn't a small, fleeting difference. It's a sustained, powerful, and durable long-term benefit seen with the Latarjet procedure. And we observed an identical concerning trend for full redislocation as well. The higher redislocation rate for arthroscopic Bankart also became particularly evident in that 6 to 10 year postoperative window, with a risk ratio of 2.85. This consistent pattern across both recurrence and redislocation, especially when observed over a longer time horizon, strongly suggests something important. It suggests that while a Bankart repair might hold up reasonably well in the very short term, its effectiveness in maintaining definitive stability significantly diminishes over the medium to long term when you directly compare it to the Latarjet procedure. It's important to mention, just for full transparency, that one single study within our analysis did show no significant difference between the procedures at the 1 to 5 year mark.
Okay, an outlier. Yes, but it's crucial to understand that this single outlier doesn't diminish the robust
overall and particularly the long-term trends we observed from the pooled data across all the included studies. The overwhelming evidence, especially looking at that broader time horizon in the large patient population, clearly points to the Latarjet procedure offering superior, sustained long-term stability. This is a critical insight.
So the long-term data really paints a very clear, quite compelling picture then. While both procedures are aiming to stabilize the shoulder, the Latarjet appears to offer this distinct, lasting advantage in keeping the shoulder definitively in place, particularly years down the line. That's a powerful and practical insight for anyone considering these options, especially those young, active individuals wanting to get back to high-level activity without that constant fear of it happening again. Now, while stability is paramount, patients obviously worry about the trade-offs, particularly complications and overall functional recovery. There's a common perception, I think, that perhaps more invasive procedures like Latarjet might carry inherently higher risks. What did your meta-analysis truly reveal about complications? Things like infection, hematoma, maybe issues with the screws or anchors, and perhaps even more importantly, how do the two procedures compare in terms of patient-reported functional outcomes, those scores that often reflect quality of life after surgery?
That's an excellent point and a very common concern. Our findings on complications really do challenge some long-held perceptions, which is, in itself, a significant takeaway from our work. When we meticulously looked at various surgical complications, the picture was, as you hinted, quite nuanced and often surprising. For instance, regarding infection, our analysis presented a genuinely surprising finding. The Bankart procedure was actually associated with a lower risk of infection compared to Latarjet. The risk ratio was 0.16, with a statistically significant p-value of 0.0002.
Lower risk with Bankart. That is surprising.
It is. It means Bankart patients were considerably less likely to develop a post-operative infection based on this data. Now, it's vital to acknowledge a limitation here. The number of studies reporting specifically on infection was relatively small, only 3, and the definitions of infection weren't entirely standardized across them. However, based on the available evidence, it does suggest this is a real, albeit potentially small in absolute terms, difference. It's certainly a point for surgeons to be particularly mindful of with the Latarjet. However, when we examined other anticipated complications, that common perception about Latarjet being inherently riskier simply didn't hold up in the aggregated data. For hematoma formation, that's a collection of blood near the surgical site, we detected no significant difference between the two procedures. The risk ratio was 0.20. Similarly, a specific concern often raised about Latarjet relates to screw-related complications, given it involves fixing a bone block with screws.
Right, you'd think that might cause more issues.
You might, but our analysis found no significant difference in screw or anchor-related complications between the two procedures. The risk ratio was 0.17. This suggests that the presence of screws for Latarjet does not, on the whole, lead to a higher rate of implant issues compared to the anchors used in Bankart. So when we synthesize the overall complication profile, it becomes quite clear. Contrary to perhaps popular belief or historical apprehension, our comprehensive review demonstrated no significant difference in most major treatment-related complications. Beyond that specific, albeit small, observed difference in infection rates. This is a crucial finding. It can profoundly inform patient counseling. It suggests that the superior long-term stability offered by Latarjet does not generally come with a higher burden of overall complications. That's a very powerful message for patients and surgeons.
That's a huge finding, honestly. Challenging what many might instinctively believe about more complex procedures versus simpler ones. It implies the benefits of Latarjet and stability aren't necessarily offset by a higher risk of adverse events overall. What about the long-term health of the joint itself? The development of arthritis? That's a major concern for patients looking decades ahead.
You're right, long-term joint health is absolutely paramount. Moving to long-term arthropathy or the development of degenerative joint arthritis. This was another rather unexpected outcome based on the available data. Primarily reported in one key study within our analysis, we found no significant statistical difference between Bankart and Latarjet procedures in the likelihood of developing progressive arthropathy. The risk ratio was 0.34.
No difference in arthritis risk.
Right.
Despite the difference in instability.
Exactly. And this is perhaps surprising, especially when you recall our earlier discussion about the known strong positive correlation between recurrent instability and the risk of subsequent arthritis. Logically, given Bankart repair was linked to significantly higher ongoing instability, one might intuitively expect it to lead to more arthropathy over time due to that continued microtrauma.
Makes sense. So why wasn't that seen?
Well, one potential explanation might relate to the maximal follow-up periods of the studies included. While up to 10 years is substantial, the onset of clinically significant symptomatic arthropathy might often occur beyond that 10-year mark, meaning we might not have captured its full progression within this data set. It could also be influenced by other patient factors not consistently captured across all studies. Or perhaps the early signs of arthropathy are simply too subtle to be universally detected and reported within these study designs. It's an area that clearly warrants longer-term, dedicated follow-up studies.
That's a fascinating paradox then. More instability, but not necessarily more measured arthritis within the study's time frame. It really forces us to think about how long-term truly needs to be when evaluating these outcomes. And speaking of outcomes, let's turn to the patient-reported outcomes, specifically using the Rowe score. This is often seen as the patient's voice in research. What did you find there, especially given the clear stability differences you've already presented?
This is where things get particularly interesting and frankly quite nuanced. It reveals a critical point about how we actually measure success in these cases. Our analysis found no significant difference in patient-reported outcomes, as measured by the Rowe score, between the two procedures. This is despite the glaring, significant difference in objective instability rates we just discussed.
No difference in the Rowe score. How can that be?
Exactly. The mean difference was a mere 0.22, with a p-value of 0.94, indicating virtually no statistical difference at all. This apparent paradox demands a deeper look. To understand this, we need to delve into the Rowe score itself. The Rowe score, first published back in 1978, is a physician-led tool. It's designed to assess a patient's shoulder across three key areas: its stability, its range of motion, and overall function. While it aims to give a picture of patient satisfaction and outcome, it has certain nuances, critical limitations, that can obscure the true picture. Critically, the Rowe score is heavily weighted towards the stability variable.
Heavily weighted towards stability.
Yes, this means if a patient experiences even occasional residual subluxation, maybe a clunking sensation, even if they have excellent range of motion and feel functionally quite good in their daily activities, that instability component will significantly drag their overall Rowe score down. It can make the score appear poor or fair, even if other aspects are good.
So it's almost like a pass-fail on stability that can inadvertently overshadow other functional improvements. If a shoulder has any instability, even if it feels quite good to the patient in terms of movement, the score gets penalized heavily. And you mentioned earlier there are different versions of this score floating around. That sounds like it could muddy the waters even further.
Exactly right. You've captured the essence of the paradox. It can be quite unforgiving on that stability component, and that single aspect can indeed overshadow other functional gains. And yes, a major persistent problem in the orthopedic literature is that there are actually 4 different versions of the Rowe score, published over the years with subtle but sometimes significant changes made in 1978, 1981, 1982, and 1988. Unfortunately, studies often don't specify which specific version they use when reporting their results. This inherent lack of standardization in the reporting tool itself makes direct comparisons of Rowe scores across different studies incredibly problematic. It can quite literally obscure genuine underlying differences in stability when only the combined overall score is reported. Secondly, another reason for the similar Rowe scores, despite objective stability differences, could simply be if the function and mobility components of the score were significantly similar between the two groups. If patients in both the Bankart and Latarjet groups regain excellent range of motion and were able to perform daily tasks with similar ease, these components, even if stability differed, might influence the overall score sufficiently to mask that underlying difference in stability when you just look at that single combined Rowe number. This truly highlights that functional outcome is a complex, multifaceted measure. A similar composite score doesn't necessarily mean the underlying stability problem has been addressed with equal effectiveness. It's a key lesson in interpreting these outcome measures carefully. Finally, just briefly regarding operative time, one study within our review did report on this. It found that arthroscopic Bankart was associated with a shorter operative time by about 225 minutes.
Shorter time for Bankart.
Yes, but this finding was based on limited data from just that one study. So while we noted it, it doesn't carry the same statistical weight or generalizability as our more broadly pooled data for recurrence and complications. An interesting point, but needs more robust evidence, really.
That's a vital distinction, Professor. It really underscores that functional outcome is complex. We can't just rely on a single composite score number. While a patient's reported satisfaction or perceived function might seem similar, the underlying stability can differ profoundly. with potential implications over a very long timeline that a single score might not fully capture. It certainly makes you think critically about how we define and measure true surgical success. Now, while this comprehensive analysis is incredibly insightful, providing very clear trends, as you've mentioned, no single study tells the entire story. What were some of the limitations or nuances you encountered in the available evidence? Things that prevented an even clearer, more definitive picture? And crucially, what important questions still remain for future research in this field?
That's an absolutely crucial point to address. No study, no matter how rigorous, is entirely without its limitations. Understanding these nuances is key to interpreting the findings correctly and, perhaps even more importantly, guiding future research efforts. The primary limitation we encountered was the inherent level of evidence in the existing literature. While we meticulously selected only well-conducted studies, the included literature largely consists of Level 3 quality evidence, primarily cohort studies. Ideally, for truly definitive, unassailable conclusions, especially when comparing two different surgical procedures like this, we would prefer randomized controlled trials, RCTs, Level 1 evidence.
The gold standard for comparison.
Exactly. RCTs are specifically designed to minimize bias by randomly assigning patients to different treatment groups. This ensures any differences observed are truly due to the intervention itself, not other confounding factors. With cohort studies, there are inherent weaknesses and risks of bias that, despite our best efforts in the meta-analysis, cannot be entirely eliminated. Our systematic review synthesizes the best available evidence, but it can only ever be as strong as the underlying studies it incorporates. Ideally, we'd want more Level 1 evidence from well-designed RCTs. Another significant nuance that introduced complexity was the variability in the surgical techniques themselves. Even within the broadly defined Bankart and Latarjet procedures, there was a surprising lack of standardization in the exact operative techniques used across the various studies. For instance, with Latarjet, this could involve subtle but potentially impactful variations, like the precise position of the coracoid bone block or the number and type of screws used to fix it. Similarly, for Bankart repairs, we saw variations in the number or type of suture anchors used, or exactly how the capsule was handled during the repair. Furthermore, some studies even included patients who underwent additional or combined procedures.
Mixing things up even more.
Precisely. For example, some Bankart patients might have also had additional capsular imbrication, a tightening of the capsule. Or some Latarjet groups included patients who had concomitant capsular shifts. Or even a few patients who underwent both Latarjet and Bankart repairs simultaneously. This makes direct, truly apples-to-apples comparisons more challenging. The specific surgical intervention wasn't always uniformly applied, introducing some heterogeneity that's difficult to fully account for.
That's a fascinating point about the subtle variations in technique. It's almost like different chefs using slightly different ingredients or methods for the same basic recipe. And you also mentioned patient heterogeneity and unreported data. That sounds like a major challenge for robust comparison. How did that impact your ability to draw even more precise conclusions?
Indeed, patient heterogeneity in the sheer amount of unreported data proved to be a crucial and complex limitation. This is where selection bias becomes a significant concern that we couldn't fully mitigate. Many of the included studies simply did not provide detailed information regarding the severity of the instability. For example, precisely how many dislocations a patient had experienced before surgery, or, critically, the presence and extent of associated pathology. This includes vital anatomical factors like the presence and size of Hill-Sachs lesions on the humeral head, or the presence and magnitude of bony Bankart lesions where there's actual bone loss from the glenoid rim itself.
And that missing data is really important.
Absolutely vital, because it raises the strong possibility that the Latarjet procedure might have been preferentially performed for patients with more severe instability, or for those with significant coexistent bone pathology. In clinical practice, Latarjet is often reserved for these more complex scenarios where a soft tissue repair alone, like Bankart, might not be sufficient. Now, if Latarjet was indeed consistently applied to these more challenging cases, then the superior outcomes we observe for Latarjet in preventing recurrence might actually be an underestimation of its true advantage for these particularly difficult presentations.
Right. It might be even better than the numbers show for those specific cases.
Potentially. Or, conversely, it might simply suggest that Latarjet is inherently better suited for those more severe anatomical presentations, which would be a valuable insight in itself, but one that the current aggregated data doesn't fully allow us to unpack with absolute certainty. To highlight this further, it's particularly frustrating that numerous included studies did not report the magnitude of glenoid bone loss. This is a critical piece of information. Glenoid bone loss is a strong discriminator in clinical practice when deciding the appropriate surgical strategy. Without this detail, our ability to fully contextualize the results and draw definitive conclusions about patient-specific suitability for each procedure is significantly limited.
So in essence, the Latarjet group might have comprised patients with more challenging conditions to begin with, which makes its superior stability finding perhaps even more compelling. Or maybe it just highlights its specific utility for those very cases. That adds really important layers of nuance to the findings. It shows that while the trends seem clear, the complexities of individual patient factors, subtle surgical variations, always need to be meticulously considered when translating research into actual clinical practice for an individual. And it certainly sets the stage for where future deep dives might take us. Are there any other major unanswered questions that weren't covered in your current scope?
Absolutely. Finally, an important unanswered question, though it was beyond the specific scope of this meta-analysis, is the critical aspect of return to sport. For young, active patients affected by shoulder instability, particularly professional athletes or those with high-demand occupations, a primary concern isn't just overall stability or general function, but crucially, the ability to return to their specific sporting activities. And perhaps even more importantly, to return to their pre-injury level of competition and performance without fear of re-injury.
A huge factor for them.
Immense. While our review focused on objective stability and broad functional scores, this specific area of return to sport, particularly at a high level, and the comparative outcomes between Bankart and Latarjet in that regard, is a vital consideration. It requires further dedicated systematic review. The very practical, patient-centric question that we don't yet have definitive answers for in a truly comparative sense.
This really does add important layers of nuance. It shows that while the trends are clear, those complexities, individual patient factors, surgical variations, specific functional goals like sport, always need careful consideration when translating broad research into precise, individualized clinical practice. And it certainly sets the stage for where future deep dives might take us, perhaps into that fascinating area of return to sport. So, to tie it all together then, what we've unpacked today through this extensive and meticulous analysis is that while both the Bankart and Latarjet procedures are certainly effective at preventing recurrence and optimizing shoulder function, the Latarjet procedure consistently demonstrates a distinct and really quite significant advantage in maintaining robust shoulder stability, particularly over the longer term, specifically between that 6 and 10-year mark post-surgery. Importantly, this superior stability does not, for the most part, seem to come with a significantly higher burden of most post-operative complications, although we did note that slightly higher risk of infection, specifically with Latarjet. This deep dive, we hope, offers you a direct shortcut to understanding the latest, most comprehensive evidence in this critically important field. It should empower you, hopefully, to confidently engage with discussions around shoulder instability treatment. Whether you're a healthcare professional striving for optimal patient outcomes, maybe an athlete navigating these challenging decisions, or simply someone looking to stay exceptionally well-informed about leading medical advances. If you found this deep dive valuable, we'd be incredibly grateful if you'd consider rating and sharing it with someone who might also benefit from these vital insights.
Given the nuances we've discussed today, those fascinating historical preferences shaping practice, the compelling new data on long-term stability, and indeed the remaining gaps in understanding exactly how patient-specific factors, anatomy, lifestyle demands, truly influence individual outcomes. The ongoing challenge for clinicians isn't just knowing which procedure is generally more effective overall. It's about truly discerning for whom each procedure offers the most profound and lasting benefit. This comprehensive evidence serves as a crucial compass, guiding us towards better practice. But the art of medicine, as always, continues to demand a thoughtful, individualized interpretation of unique patient needs against the backdrop of the most robust scientific findings available. It's a continuous journey, really, of learning and refinement.
A truly thought-provoking conclusion, Professor, and a perfect reminder that that journey of learning, of applying the best evidence, never truly ends. Thank you so much for joining us for this deep dive today. We look forward to our next exploration with you.